My name is Winters Mutamba. I'm a research scientist at the Makerere University Lung Institute and program manager, Light TB. Slides, please. Or do I need to do it from here? So I'm happy to be moderating this session that we've called the Gender and How it Intersects with TB in Uganda, and we'll be discussing community perceptions, research findings, some of the interventions or program initiatives we've undertaken, and the policy recommendations we've made up to this point. Just to let you know that this session is supported by the Light TB Consortium that I will talk about briefly, coordinated at the Makerere University Lung Institute. This topic of TB is quite timely, especially if we are talking about global health security. As you know, the Lung Institute has been at the forefront of the global health security. Most of you will remember the work we've done in COVID-19, Ebola, and most recently, Mpox. But then we shouldn't forget that TB in its own right is also a global health security concern. And I want to pick on 3 points before I introduce my panelists. 3 key things. One, you can't talk about TB and you don't talk about antimicrobial resistance. And one big statistic that should worry each one of us is that a third of the AMR-related deaths globally are attributed to MDR-TB. That's the first statistic. 2, half of the TB cases notified globally, or more than half, among men. That again should concern you. And lastly, the last statistic that I thought I should bring out for us to contextualize this session is that 2/3 of the TB cases, or 2 out of the 3 cases of TB go undiagnosed, and most of these are in men. Ladies and gentlemen, with that, I would like to introduce my panelists for this evening. I have a well-experienced panel of panelists. I will start with Mr. Fred Ebil. So Mr. Fred Ebil is the ED of the Fellowship of TB Survivors in Uganda. He's a board member of the Uganda Stop TB Partnership, and also is a member of the Advocacy Communication and Social Pillar at the National TB and Leprosy Program. You're welcome, Fred. My next panelist is Dr. Jasper Nidoi, a research scientist at the Makerere University Lung Institute, but also is a health economist. Dr. Jasper Nidoi is an early career researcher under the Light TB program, and her research interests are around socioeconomic factors that influence TB treatment outcomes, and has been involved in many studies, including clinical trials, and by far one of those is the STREAM TB trial, which again influenced policy in terms of reducing the TB, MDR TB treatment duration from the original, I think, 18 months to what we have now as shortened oral regimens. And lastly, but not least, is Dr. Beata Ringwald, a postdoctoral research associate with the Liverpool School of Tropical Medicine, and her research focuses on addressing health and social inequalities in the disadvantaged context. And to do this, she uses participatory visual storytelling methods to stimulate dialogue between the affected communities, healthcare workers, and managers. She brings to this symposium, or to the session, more than 10 years of professional experience designing and delivering programs using participatory approaches. Quickly, before I start engaging the panelists, just 1 minute. The Light TB Consortium is a multidisciplinary, cross-disciplinary global health research program funded by the UK Aid and coordinated by the Liverpool School of Tropical Medicine across several African countries, Uganda, Malawi, Kenya, and Nigeria. And by and large, the LIGHT project or consortium wants to support policy and practice in transforming gendered pathways for people with TB in urban settings. Now to my panelists, and I will fire straight away. I will start with Beata. What is this gender thing? When someone says gender for TB, what is gender? Just break it down for us.
Thank you. We need to distinguish first gender and sex. Sex are our biological or physiological characteristics of what defines us as boys or girls, as females or males, as women and men. So we are assigned usually a sex by birth. Now when we grow up, we are socialized into a society, be it in Uganda or where I grew up in Germany, and that socialization is largely gendered. It is determined by norms and expectations of what it is to be a boy or a girl. It is the roles we are grown into to take on as boys and girls, as women and men. And that's what we think about today when we mean gender. It's really about our socialization and what is expected of us and how that may put us in harm's way and put us at risk of tuberculosis or put us at a disadvantage to receive care for tuberculosis. So that's what we're going to discuss today. Thank you.
Thank you, Beata. As I mentioned, we're privileged to have someone who has the lived experience for TB. And quickly, Mr. Ebil, kindly take us through your journey as someone who has lived this experience. What does it mean for a man, for you as a man, to have gone through this sort of experience as a TB survivor or TB patient?
Yeah, thank you very much. Once again, good afternoon, ladies and gentlemen. As it has been mentioned, I'm called Fred Ebil. I'm the Executive Director of Fellowship of TB Survivors Uganda. Some of you might have heard about the organization. This is a network of the TB survivors that actually, after a long suffering, they came together and form up the network. Briefly, in my journey, it has not been easy. By the time when I realized that I've been diagnosed with the multi-drug resistant TB, it took me long actually when it was now a bit late for me when they discovered that actually I'm having MDR. And when I was taken in the hospital, from 70 kgs, I came up to around 30 kgs. And when I was brought actually at the facility, I couldn't believe, because when I started my treatment, I saw a number of people that when they are brought for admission, the very first day when they brought about 3 people, all these people, late in the evening, they all died. Then I was almost like, I said, I think this could be a war zone area, because I couldn't believe that actually I could be a person that actually I talked to you people at this time. It has not been easy. When I was told that I'm supposed to go through a treatment of 2 years, then I almost asked the doctor, I was just asking like a fan, that is it true that what you are telling me, it is true, or you are just cracking jokes? The doctor told me, said, no, you have been diagnosed through multi-drug resistant TB, which is really a treatment which will take you through 2 years. I couldn't believe by that moment, and what she told me that I'm going to be on medication. Each and every day I will be taking 16 tablets, and every day I'll be getting injection for 4 months. So when I heard of all this, I almost lost temper. Some of the things which was coming in my heart when I was in the ward, somehow, somewhere, I normally tell myself, I said, no, I think what I should do with all this, I can't bear this situation. The only thing I feel like to do, I should at least, if I can chance at least to get all this medicine, I can take like 40, so that one could be the end of me. So it wasn't easy, but as a man, there was a number of challenges, because in my being at the hospital, you know, as a father, you are almost the breadwinner at home. In my hospital, even you find even my woman at home, she's even still coming, even asking me that at least you see today we don't have food. The children are crying, things are not okay. So with all that situation, I felt that now, with being here for 2 years, when even my children, they are supposed to be at school, my woman also, somehow, somewhere, when things get worse, she might even disappear. So it is through God's willing that I started the treatment. I went through the treatment. After a duration of about 2-3 months, I started getting better. I went through the kg I found when I had added to 35. The good part of it that we were being supported with some food. We normally eat at least good food. So somehow, somewhere, things went on somehow better. But it was not an easy thing, because by that time I was working. So when I felt somehow better, then I requested the hospital. I said, no, since I'm the breadwinner at home, let me at least get back, because at the workplace, they were almost even actually replacing me, because they said we cannot keep you for all that duration in the hospital for 2 years when actually we need your service. So I requested that actually is supposed to go back. But when I got back at my workplace, I started experiencing a lot of stigma. You know, people, when they are told about TB, people just take it slightly. But this is not something that actually we shouldn't take it slightly. It's something which, when you don't actually pay much attention, it is really, it ruins the whole family. When I got back to my workplace, the first day when they heard about, because they heard about that I was in the hospital, I was diagnosed of TB, and they heard of that it is MDR. Other people, when they hear about MDR, they automatically know that this is a TB which doesn't get cured. So when I got back to the place of work, I saw the way how other staff of mine, when we are going to serve food, once the plate which I've used, the plate somehow, somewhere, they normally leave it aside. They don't want actually to bring. And when actually I'm going for food with other staff, I'm always served last, because they fear that when I join other staff in the process of getting food, they will also be. So I started getting a lot of difficulties. There was stigma, discrimination. Then time came when I said, no, with all this kind of situation, I feel I can't continue with this. So I just made up my mind. I said, from this point, I think I'm going just to finish this place this week. I cannot continue anymore with all this thieving. Otherwise, my life will just go on like that. So time came when I just decided I left, because I just knew even the heads of department, other people, they were not even now interested in that. So I left, and then I came back. Since that time up to now, I said, no, with this I cannot just sit to wait. I got back at home. I stayed like for about 6 months when I was doing nothing. Things were not easy. When you would knock in other doors to look for other work, things were not easy. Then I said, no, I must be an advocate in this kind of situation. So I just said, let me try to begin organizing myself, at least to form up a network.
Okay.
And that
Fred,
is what
I will come to that. I know that you've been at the front line of influencing TB care among men, and I'll come to you shortly. But Dr. Nidoi, I know as a research scientist, you've had what Fred went through. But before I come to you, I think there are some key terms I needed to probably simplify. MDR TB. So most of us use the TB that we treat with the readily available, the commonly available drugs, or what we call the drug-susceptible TB. So this is normally treated with drugs that ideally, for a short time, we treat this for 6 months. And then for the drug-resistant TB, this is the TB that doesn't normally respond to what we would call the first-line TB treatment. And until recently, we're treating MDR TB for 2 years, like he mentioned. So you can imagine being put on TB treatment for 2 years, both injections and orals. I don't know how many of us would handle. I think some of us can't even manage to complete a 5-day course of antibiotics, so you can just imagine. And because of that, most people give up, and you end up getting issues around MR. We had challenges that men go through. The increased demands at home, at work, job loss, issues around stigma and all that. And Jasper, you've been doing a lot of research on how to respond to some of the issues around TB in men. And could you kindly take us through what, from a research perspective, we need to do to respond to some of those concerns or challenges around TB care in men?
Yes, so all the challenges that Fred has talked about, when we go to the field and speak to healthcare workers and speak to former TB patients, we come across the same challenges. And as Beati mentioned, this is really centered around the norms and values that society puts around men. I know some of us who look at the health sector annual performance report really see that health facilities are frequented by women. We look at the percentages, men are fewer in health facilities compared to women. The doctors here in your practice, you see the same thing. Also, Fred has touched upon poorer health outcomes among men, and also them coming into the health facilities when they are quite sick. So as a researcher, we looked at some of these factors. We went to several facilities, we engaged key stakeholders, and we tried to document this. And maybe just starting on some of the work that MLI has done, some of this came out resoundingly almost 10 years ago when we did our first prevalence survey. And the prevalence survey done in 2015 showed that TB is 4 times more prevalent among men compared to women. And when we also look at the notification, because we do notify cases, we're notifying more TB among men and women, but compared to the burden of TB that we know is among men, we find that many of the cases that are missed are among men. So Uganda has a male involvement strategy, but there were no gender-specific guidelines targeting TB screening, particularly among men. And when we go into a gender-sensitive approach, it doesn't mean that we're leaving out women or children or other age groups, but we need gender-sensitive approaches to address the male-specific needs and try to bring them onto care as we continue providing services to all the other groups. So under the LIGHT Consortium, we conducted a study that was focused on gender-sensitive TB screening services, and we really looked at public health facilities. Winters didn't touch on this, but the LIGHT Consortium is doing work in many countries, and in Uganda we focused on the public healthcare system, while in Nigeria they focused a little bit on the community. So we used a participatory approach where we went to the facilities, the facilities that we wanted to implement a study in, invited TB survivors, healthcare workers, and other stakeholders that we thought were relevant, district officials, for a co-design meeting, and we came up with 3 main interventions that would address the higher burden of TB and the missed TB cases among men. We thought we'd introduce male-friendly services in these health facilities, and this included integrated screening for TB, HIV. We also added diabetes and screening for hypertension within the TB clinic. From the engagement that we've done with different stakeholders, we also saw that it was important to engage a male champion. We know that 2/3 of the healthcare workforce is female, and we felt that this engagement with a male TB champion, a male TB survivor, would be helpful and beneficial. I think we've all learned a lot from Fred's experience. We also improved screening for all using a summary stamp for all TB symptoms, and we gave out informational material in the community. So we assessed the feasibility, effectiveness, and cost effectiveness of this intervention, and recently we had a data validation workshop. As I've mentioned, participatory methods have really been key throughout the whole experience. So we went back to the facilities in which we implemented this study, disseminated the results, and also looked for explanation and meaning behind that. So I'll just highlight a few results that we found. So we implemented this intervention in 2 public health facilities, that is Gombe and Mityana, with 2 controls, Luwera and Chiboga. So briefly, we can see that in Gombe, this was a quasi-experimental study over 1 year. We can see that in Gombe, the TB notification increased by 46.3%. While there was no improvement among women, it remained the same number of women in the before and after period. We see that this male-specific strategy increased TB notification by 88% among males, while in the other intervention facility, Mityana, there was an improvement in both female and male TB notification, 26% among women and 45% among male. In the control facilities, we saw that there was a decline in TB notification. So the take-home message from this is that TB male-specific strategies can improve TB notification among men without negatively decreasing notification among age groups, particularly women. For those that are interested in statistics, we see that this was beneficial. So it was statistically significant, and also males at baseline still had a higher notification, about 50%. So I've mentioned participatory review. We went back to the facilities to see how they implemented the intervention and if it was implemented as desired. So screening using a summary stamp that summarizes all the symptoms was found to be easy. The tools were readily accessible, and the healthcare workers actually still reported that the stamp or the improved screening was reaching more women because still women predominated the healthcare facility. But we see that with this improved screening, we had a significant improvement among men. I think I'll stop there for now.
Thanks, Dr. Nidoi. I picked something from you. I actually didn't know that we have more female healthcare workers than male. But also what I know from the brief interaction I had with the men is that they view healthcare facilities as female spaces. So you can see you don't only have to interface with female healthcare workers, but the people around you when you get to these facilities are actually females. Probably that's one of the challenges, and I like the fact that you hinted on male-friendly services. And I want to bring in Beata. She just worked with healthcare workers. And I know, at least from where I come from, in terms of epidemics and all that, some of the interventions we've actually discovered that if we worked with the end beneficiaries or the recipients, including people who have lived this experience, they are more easily taken up. And I know you've been an advocate of social sciences in research. Quickly take us through how we would approach issues around men and TB from a social sciences angle.
Thank you, Dr. Winters. So I think we've all were touched by the story that Fred shared with us, his journey from the onset of the symptoms and how he moved through treatment, and even when he was cured, it didn't end there. The TB label stuck with him. And I think that we need to understand exactly these circumstances of men, women, and children under which they live and work and study and grow more in depth, and that's the methods I use. So I use visual methods, some of which that Dr. Ndoye has talked about. I use photo voice. We do transects walks, so we go through the community, guided by community members, to understand where do men, women, children live, where do they sleep, where do they study, where do they work. Because our health response will only be as good as we know our epidemic. And thank you, Fred, for sharing your story. When I come to how prepared we are in this research, I think there are two things I want to highlight around. One is gender is largely conflated to be women. So it's we are a bit outside the norm to talk about gender and men and TB. But I think it's important that we understand both the experience of women and the experience of men, so that we are able to come up with ideas and interventions that will enable them the access and the retention in care and the support they need. The other aspect is that social sciences may not play the greatest role, but an emerging role in tuberculosis research, and that's good because we have heard from Fred the story that he shared with us, and I think we can learn lessons from that, and we have done research in all the 4 countries of light, and every day we learn something new from people with TB, and not only their challenges, but also their ideas on how we can make things better.
Thank you, Beata. I will still stay with you. And I think from Fred's moving testimony, it's apparent that there are many people out there like him. And from where I stand, I think this is probably a huge resource that we could tap into to improve TB programming. And I know, again, you are an advocate of something they call photo voice. So using the photo voice, how can we pull this huge resource of TB survivors to try and probably better or improve TB programming?
Let me first come to the numbers. You said there are more, there are many people like Fred. So globally, 10.6 million people develop tuberculosis disease every year. Most of them survive and are cured. In Uganda, it's more than 90,000 people every year. And there was a recent global study that tried to estimate how many TB survivors do we have, how many people have gone through the experience of TB, have survived it, and that number may be 10 times the annual number of people who have been cured. So we can expect in Uganda we have 800,000, maybe 1 million TB survivors, and that's a huge resource. These are people who know how it feels to go through the disease and the treatment. I also believe that there are not many people like Fred who get a chance to work within the formal health system as cough monitors, treatment supporters, village health teams, all those voluntary roles, these close to community providers that bridge the gap between affected communities and the formal health system. And I believe there are many more who do in their day-to-day life their little contributions to prevent and to respond to tuberculosis in their family and their community. And I think we can best document such experience through stories, and we use photo stories because a picture tells more than 1,000 words. So we give people cameras, we train them on ethics, on photography. We want to give them cameras to document how their day-to-day life looks like in their TB survivors, what they do to end TB in Uganda. And we hope to learn a lot from them and be able to come up with ideas how to support TB survivors in Uganda. We are very hopeful that this method will work because we have worked with it in other countries. In Malawi, we have worked with young people who have TB, and they have allowed us to very close in their intimate lives. Young men as caregivers, young men have shown us their mental health challenges, young men have shown us their vulnerabilities, young men have shown us that they were running businesses before they had TB and how that crushed, how TB has disrupted their education. So all these touching stories resonated very much with policymakers, and we hope that stories of TB survivors, not only their suffering, but also their contributions they do every day in their lives, that's what we hope to document in this study that we will start soon.
Thank you, Beata. I will come to Fred. Like I mentioned, you're a founding member of a TB survivors network or forum. How are you using this platform to draw TB survivors into the TB response? And are there other ways we could probably engage them?
Yeah, thank you very much. Yeah, I think that's a very good question. As I told you earlier that we have realized that even inside here, when you are to just give a sample of about 5 people and ask them about TB, most of the people, maybe the medical workers can understand much, but what we have realized, we have gone actually deep in different communities. We have realized that if you are to ask a person about TB, most of the people they doesn't know. So as the network, we have now moved far to make sure that we let people understand. And basically, Fellowship of TB Survivors Uganda, they are on advocacy, communication, and social mobilization. We are doing a lot of advocacy in the community, and we are basically in the community. We normally create awareness. People, we want them actually to understand that when you get TB, you can get cured. When maybe as a man, once you have already realized that you're sick, please don't just sit at home. You take up yourself, at least you go to the hospital. And that is one thing. In fact, I want to thank MLI through Light Consortium. We have realized that for quite long, people have not been looking into men. But I want to tell you that the greater percentage of people that are getting TB are men. And it is good really that Light Consortium is doing really a lot of research, and that is one of the ways that as Fellowship of TB Survivors, we are working together with Light Consortium to see that in the community we create awareness, because people are really not understanding when you ask them about TB. And that is why most of the people, when you go to different facilities, a greater percentage of death cases at the facility, it is death. I mean, it is actually, it is male. Men, they are the greatest percentage when it comes to death in the facility. So as the network, we are doing community awareness, and we are doing advocacy, communication, and social mobilization. Thank you.
Thank you, Fred. I think, and I hope everyone is a little bit worried. We're talking about men, but some of us have women and children in our lives. And the fear is that we might concentrate on men and forget about the women and children, even in the worst case scenario, lose some of the progress we've made in TB programming for women and children. Jasper, doesn't that worry you? And if it does, how best can we ensure we strike a balance?
Yes, so that's a very important question that you get when you're doing gender-specific work. And the approach that we are taking is, if you pretend to be blind, if you implement gender-blind approaches, you will still disadvantage one group over another. You touched on the fact that men view health facilities as spaces for women. This is something that has been documented. Recently, a gender and key populations report was conducted, and the same thing came out, you know, the health basket that health services offer, from antenatal services to immunization and all the like, favor women as caregivers to approach healthcare facilities. So by bringing in gender-sensitive approaches, we want to bring men onto care and not implement health services that are gender neutral, gender blind, and do not take these different healthcare needs into consideration as we design interventions or as we deliver care. And in this, we also improve services for all. As I mentioned, we introduced a summary stamp that really summarizes the cardinal symptoms of TB. And from the interviews, the key informant interviews we conducted with the healthcare workers, they've been able to tell us that this really simplifies screening. And as we saw, they still reported that women are benefiting from these services more. It's just that we are introducing selected services like the male-friendly services to attract men onto the healthcare system. And one important thing to note is that a person with TB who's undiagnosed has the potential to spread TB to 5 to 15 people within a year. Who are these people? Women, children, and other members of the community. So by putting emphasis where the issue is of undiagnosed TB, the final benefits are to the entire society. Thank you.
We have also trained or capacity strengthened and worked with the Ministry of Health, with the national TB programs, with sub-county TB focal points as co-researchers, with Ministry of Genders, to early engage them and interest in our study, but also train them in evidence-informed decision-making, because we think it's important to be able to read research, whether it's photo voice or some statistics, and to be able to assess the quality and use that for decision-making. So we have worked on several pillars simultaneously to be able to sustain these ideas. And again, the participatory methods are meant to bring people from the community and the decision makers together. So we are not working in silos and making our data analysis in some offices. And I think these conceptual impact, the capacity impact, the relationships that we have built, they will continue and carry on this kind of work. Thank you.
Thank you, Beata. And I think that probably can be picked up by anyone involved in whatever kind of research, that you need to work with the people who will consume this research, the policymakers, the Ministry of Health and all that. So I think that's quite a good thing that the Light TB Consortium is doing. Now we have an opportunity for 2 questions. I don't know if there is any burning question from the audience. We can take 2, if any, before we wrap up. Oh, there is one.
Okay, this is Irene Najingo from Lung Institute. Thank you so much. The TB survivor, you raised something very important, and I think really community awareness is very key. Thank you so much. But this question goes to Dr. Jasper. What is your take home? What is that intervention that you feel is very important at the health facility to improve TB screening among men? So if I went to a health facility tomorrow, what should I tell the healthcare workers? What that take home from all the interventions you've talked about?
Thank you, Irene, for that question. So what we have, the take-home message really is what the NTLP is advocating. Everyone who comes to the healthcare facility, regardless of their care entry point and regardless of the services that they have come to seek, should be screened for TB. So with the intervention, we're trying to improve screening to make it systematic, and I think that is what has led to the remarkable improvement. Because when we look at the TB cascade, we see that there's been improvement in the number of people screened, improvement in the number of people presumed, and ultimately the number of people notified. We put emphasis on men. We're able to present the same statistics that we've presented here to the healthcare workers and increase their awareness. So you'll find that departments that were really not notifying any case, like maternal child health, we have started to screen both the mothers and their partners who accompany them. So you find that the men who are coming were not being screened in some of these departments. So the point is screen everyone for TB, and this is what the NTLP is also advocating for. And as researchers, we are coming on board to see how we can make that practical and really ensure that screening is improved.
Thank you. Any last question? One last one, and the far corner. This way? Oh.
Thank you very much for your presentation. My name is Mwaka Edwin John. I'm a clinical epidemiologist. You have given us stats on the different novice cases, but we haven't yet had the recurrences across the gender. Thank you.
Okay, I hope you noted that. Did you get it? You want to come back on that? Sorry.
I'm trying to be clear. I was behind this and the noise. We have the stats on the novice cases, the MDRs that you were giving us. But there are patients who have healed from TB, then a few months or years down the road, they recur, then they heal, then they recur. We don't have those statistics across the gender for the male, the children, and the female, but you have been giving us the others. Thank you.
Yeah, thank you for that question. We'll respond after. I think there was one, very last one. And then maybe you can respond while he, who wants to respond, who wants to give it a shot?
Yes, so Beati has mentioned some of these things that we're doing to ensure that what we're doing under light is sustainable. So what you've mentioned, I think you're talking about relapse, TB relapse, right? So what you've mentioned is sex disaggregated data, and right now we are trying to work with the National TB Program to have sex disaggregated data along the continuum, not just for relapses and all of these other conditions, to have sex disaggregated data for most of these indicators for TB to guide policy and to guide areas that we could look at. Just giving an example of the Gender and Key Populations report, we found that MDR TB, the failure rate was higher among women compared to men. So that is an area where women have poorer outcomes. So by us having sex disaggregated data for all of these TB outcomes, including relapses, it will be very helpful. And maybe the other thing is post-TB lung disease, because that's maybe one of the reasons that people come back to the healthcare facility without, they got TB treatment, they are maybe declared cured or completed, but they have these persistent symptoms of TB. So there is some work that MLI is doing around that. We have just completed a post-TB assessment report. Unfortunately, the team that did that is not here right now, but work is also being done in that area. I don't know if Fred, if you want to add something? You want to add?
Yeah, thank you very much, my brother. I think that's a very good question. As Fellowship of TB Survivors, this is also one of the things that we have realized, because we got a number of questions from most of the survivors, that after the treatment, about 2-3 months, you find again somebody is actually not okay. So we have realized that we are requesting actually the government that if possible, after the treatment of a patient, when actually he has been discharged, that particular person is supposed to be assessed for 3 different consecutive sessions. Because most of them, we have realized that somebody go through the treatment of TB, but he could again be having any other lung disease. So the post-lung disease is one of the issues that is supposed to be addressed, and we are looking into that most of the survivors, they need to be assessed, because that is one of the issues which is actually coming on board again. Thank you.
Thank you, Fred. And Jasper, one last question. I hope it's brief.
Yeah, it's a brief one. I just want to inquire, what is the goal for the fellowship of the TB survivors? And I also want to know how are you addressing the triggers of multi-drug resistant TB amongst your survivors? Thank you.
Okay. Quickly, in a few seconds, if you can respond.
Thank you very much. He actually asked about our overall goal. Our overall goal is just to end TB and its impacts by 2030. What is actually we doing that actually we have to pedal through the multi-drug resistant TB. We are really appreciating what is actually the researchers they have done, because we have realized that from the 2 years that we have been going through the treatment, at the moment, the multi-drug resistant treatment, it has now come back up to around between 9 to 12 months. And this is basically what actually we are advocating for, that we still need the researchers to do a lot to see that at least 9 to 12 months is even still much, because when a person keeps on taking medicine, like 14 tablets or 16 tablets every day, it brings also some of the impact. So we are saying if the researchers can still do a lot, so that at least we reduce the month for this treatment, at least to 4 months, that is multi-drug resistant TB, and then susceptible TB can even actually be 2 months. So that is what really us, Fellowship of TB Survivors, we are advocating that those months that have been put is still much. Thank you.
Okay, thank you, and thanks to the audience for the questions. As we wrap up, just a few take-homes. Like I mentioned when I was starting, TB threatens global health security. It even becomes more concerning when you look at MDR-TB. I mentioned that 1/3 of the deaths reported globally are attributed to MDR-TB. And one way to probably reduce this is to identify the TB patients, initiate them on treatment early, and make sure they complete it. And I'm happy that the Light TB Consortium is doing all that is possible to identify these cases and have them initiated into care. We also noted that there are more men missed with TB, and Jasper mentioned that 5 to 10 unidentified or undiagnosed or unnotified TB patients. No, actually one TB patient spreads to 5 to 10 people per year. Now imagine the cumulative of the multiplier effect if we do not identify these patients and initiate them on treatment early. So thanks to the Light TB Consortium and the Makerere University Lung Institute for bringing together this panel of experts to discuss this very pertinent issue.